Hi and hello, welcome all once again back to the one more session from the Cycle to Basic module of Antimicrobial Stewardship that was organized by FCPI. And today we are going to learn about prospect point surveillance survey and studies. And the speaker is Dr. Vrinda Nampruthi. And she is one of the eminent research person in this complete qualitative analysis of antimicrobial stewardship, and also she completed her PhD recently. And also she's also working on many projects that is collaborated with other countries like UK, South Africa, India. And recently she had selected as emerging leader in infectious International Society for Infectious Diseases. And she is currently working at Amrita Hospital, Kochi, Kerala, and also she's working as an postdoctoral fellow and researcher too. So without any delay, I want to hand over the session to Dr. Vrinda. So now the platform is yours, ma'am.
Thank you so much, Satya, for that very brief introduction. I'll just quickly share my slides. Right. I hope my slides are visible.
Yeah.
Okay. Hi, everyone. Thank you so much for joining this session. So today we'll be discussing about point prevalence survey. Uh, I'm sure many of you would have heard about this process and how and this terminology, but you may not be familiar with how it is done and how you present the data and things like that. So I hope in the next 30 to 40 minutes, I'll be able to give you an overview of what this process is and how you as a clinical pharmacist can do this in your hospital setting. So before I begin with my presentation, I would like to state that I have no disclosures to declare. So in this presentation, we will be discussing about what point prevalence survey is or PPS is, how you conduct a PPS in a hospital setting, and how do you report and present the findings of a PPS to clinical teams. So what is point prevalence survey? So to understand PPS, there are some key aspects that you need to first be aware of. First is point prevalence survey gives you an idea about prescribing patterns or prescribing behaviors at a point in time. So it is very much you get an idea about these kind of practices and behaviors at one point in time. So say if you're conducting a point prevalence survey in a medical ward in your hospital at 8 a.m. on a particular day, you only see the prescriptions of antibiotics which are active at 8 a.m. on that particular day. So what has happened before that, what has happened with the antibiotic prescriptions before that, or what will happen with the antibiotic prescriptions after that, you won't be able to get an idea about. So that is one major distinct feature of PPS, that is, it happens in a point of time. And so by definition, it helps you to collect information on prescribing practices of antibiotics and other information relevant to treatment and management of infectious diseases in hospitalized patients. So let's look at some of the key strengths and limitations of PPS. So like I mentioned, it provides an overview of the antibiotic use, but you don't get to understand or analyze prescriptions from an overall perspective. So say suppose there was an inappropriate antibiotic prescription which was being administered to a patient in that medical ward, but it stopped at 7 a.m. on the day of PPS, and you're doing your PPS at 8 a.m., you would have missed that prescription. So when you go and do the PPS, you will see that all the antibiotics are being prescribed appropriately for the patients in that ward. And then you might conclude that, antibiotic prescribing is quite appropriate and they are complying to the guidelines. But you might have missed out on the inappropriateness which stopped before you went for PPS. So that is one limitation of PPS, that is, you don't get the overall picture. The second is it helps you to assess compliance to guidelines. So we'll discuss about different PPS methodologies in the coming slides, and there we'll understand how this is done. And the limitation is that it can become a bit resource intensive in comparison to collecting antimicrobial consumption data. So those of you who have done outcome measures and you have calculated DDDs, consumption matrices, and all those things, you would have just got this data directly from your hospital information system or from your pharmacy records. So in comparison to that, when you're doing a PPS, the designated people will have to actually go in person physically to the wards to collect data on their designated forms, then maybe come back and enter this data on a web platform. So in that aspect, it is considered to be a bit resource intensive. But actually, if you compare it with, say, another intervention like prospective audit and feedback, this may not be a very time consuming or a very resource intensive process. So only in terms of comparing it with antimicrobial consumption data acquisition, this can be a bit resource intensive. Okay, so now we'll just discuss about some of the major methodologies for doing point prevalence survey at a global level. So the first one that we'll be discussing about is healthcare associated infection PPS, which was developed by the European Center for Disease Control. So this PPS protocol is specifically for hospital-acquired infections and antimicrobial use in acute care hospitals, and it was developed through several expert meetings organized between 2009 and 11. And this PPS is conducted in the European countries once in every 5 years. So the first ECDC PPS was conducted in 2011-12. The next one was between 2016 and 17, and the third one was between 2022 and 2023. So this PPS model is conducted among the European member states. So this was one of the initial, like globally, this was one of the initial PPS protocols developed. Then some of the more used PPS models or PPS methodologies are the WHO PPS and the global PPS. Many of you might be familiar with these PPS models, and I don't know if any of you have used any of these methodologies. So we'll just discuss one by one. The first is WHO PPS. So this is a manual that has been published by WHO, which elaborates in detail on how the WHO PPS model or methodology can be applied to hospital settings. So some of the key features in this is that one, it is an adaptation of the ECDC PPS protocol that we discussed. And in the WHO PPS model, it collects basic information on the management of infectious diseases from medical records and associated patient documentation on all hospitalized patients. So in ECDC PPS protocol, we saw that it is basically collecting information about hospital-acquired infections and antimicrobial use. Here, it is mostly around antibiotic use that the information is collected. So WHO has developed several forms for this data collection. So there are a lot of forms that you need to fill out if you're doing WHO PPS. So before moving into the forms, we'll just discuss about the eligibility criteria. So WHO has defined very clear eligibility, inclusion, exclusion criteria at different levels. So at the hospital level, this protocol is applicable only to acute care hospitals. So other facilities like, say, nursing homes, rehabilitation centers are excluded from this protocol. At a ward level, only acute care inpatient wards are included. Others such as long-term care wards, emergency department, day surgery wards, daycare wards are excluded. At a patient level, patients hospitalized as an inpatient at or before 8 a.m. is only considered or only included for the survey. So if there is a patient who has been admitted to the same ward at, say, 9 o'clock, they won't come into the patient cohort for PPS. And other settings like outpatient clinic, emergency room, dialysis unit, these patients will also be excluded from this PPS model. Coming to antibiotic, only systemic antibiotics will be included. Topical antibiotic, ophthalmic antibiotics will be excluded. And also, when you are doing the PPS, like if you have set your PPS for 8 a.m. on a particular day, if the antibiotic has been stopped before 8 a.m. or it has been initiated after 8 a.m., it will not be included for that PPS. So when you go for PPS, that is, say you set your timing at 8 a.m. on the day of PPS data collection, at 8 a.m., the antibiotic should be actively being given for the patient. So it should be an active prescription. Only then it will be included for your review. So like I mentioned, there are a lot of forms which you need to fill out when you're doing WHO PPS. The first is a country form, which basically collects data at a national level. So the name of the country, how many private hospitals are there, how many public hospitals are there, how many primary, secondary, tertiary hospitals. So things happening at a national level, so including whether there are antibiotic treatment guidelines available, where national treatment guidelines are available. So those data which you can acquire from a national level is collected in the country level form. The second form is a hospital form, where you collect data about the hospital where the PPS is being conducted. So whether how many beds are available, how many ICU beds are there, the admission rate in the hospital, those matrices are captured in there. The third is ward form. So when you're doing a PPS, you need to decide which particular location in the hospital is where you will be doing your PPS. So if you're doing it in your medical ward, in the general medical ward in the hospital, you enter the details regarding that particular ward in this form. So which was the ward, how many patients were there on the day of the surveillance, how many included patients, how many eligible patients, all those things you enter it in this form. The next one is the patient form. So it is basically capturing the patient demographic details, underlying infectious diseases status, comorbidities, hospitalization, all those things are captured in this form. The next one is indication form, where you are giving details about what the specific indication is for the antibiotic to be prescribed for the patient. So whether it is hospital acquired infection, community acquired infection, surgical prophylaxis, medical prophylaxis, all those things. So that is captured in this form. And if the patient has a culture that has been sent to the microbiology lab, you have a separate microbiology form that needs to be filled. The next is antibiotic form. So there are two antibiotic forms wherein you capture all the details regarding the antibiotics that are prescribed for that particular patient. Only active antibiotics at the time of surveillance is included. So like I mentioned, if the antibiotic was stopped before the time of surveillance, before the time of PPS, it is excluded. Only antibiotics that are active at the time of PPS is written or is included in these forms. So whether it is the name of the antibiotic, dose, duration, frequency, route, everything is captured in these forms. And like I mentioned, if the patient has a culture that has been sent, detailed regarding the culture specimen and the report of the cultures is captured in this microbiology form. So this is how the WHO PPS is done. The next one is global PPS. So in global PPS, this is basically a freely available web-based tool to measure and monitor antimicrobial prescribing and resistance in hospital and other healthcare centers worldwide. And there are a lot of publications that have come out of this collaboration, and you can see various hospitals, various countries which have used global PPS model to assess their antimicrobial prescribing patterns in the country. And it basically provides a quantifiable measure to assess and compare quantity and quality of antimicrobial prescribing and resistance both in the inpatient, outpatient, and in the various patient populations. Okay, so what is the aim of PPS, global PPS? So basically, it has three aims. First is identifying the burden, second is changing practices, and third is measuring impact. So identifying burden means you are evaluating the antimicrobial prescriptions to understand the practices, and change practices when you are after you have done the PPS and you have seen certain results from your PPS, you develop some interventions and you identify targets for quality improvement, and you implement those interventions in that particular unit. So if you see during your PPS, if you see that a lot of patients do not have a documented indication for antibiotic use, you can put in an intervention to improve that process measure, and then you see whether this particular intervention has helped in improving the compliance to that particular process measure. So in that way, global PPS happens in 3 levels. So first you understand what is the issue, then you implement certain interventions, and third you sort of evaluate or assess the effectiveness of that intervention. That is that assessing the effectiveness of intervention is again done through repeated PPS. So in this, again, the inclusion exclusion criteria is quite similar to the WHO PPS. Here again, you include all patients on active antimicrobial prescription at 8 a.m. on the day of the survey. And antimicrobials for systemic use is only included, topical use is excluded. And other exclusions include day hospitalization, ambulatory care patients, and patients admitted to the ward after 8 a.m. on the day of the survey. So it is pretty similar to what we have already discussed. And here again, you have a few forms, but compared to WHO PPS, the number of forms here is a little more less. So the first form is a ward form, where you enter details about the ward where you're conducting your PPS. So whether it is a medical ward, surgical ward, ICU, and like we mentioned in the previous one of the previous slides, in global PPS, you're also looking at hospital-acquired infection rates. So for that, you also collect data on those patients in that particular ward who have indwelling catheters or tubes. So those who are having urinary catheters, IV catheter, so and other drains and tubes, you collect the data on that on those numbers as well. The next is the patient form, wherein you collect basic patient demographic details, and in addition to that, you also have the biomarker details of the infection biomarkers, as well as cultures in the same form. Also, the antibiotic details are also, everything is included in one form. So in WHO PPS, you saw that each of these is different forms. So patient demographics is one form, culture report is another form, antibiotic use is another form. So here, all those things have been sort of compiled into one form here. So in this, if you see, let me just put out this pointer. Okay, so here you see that there is one row that says diagnosis, and they've asked you to refer to appendix 2. So they have actually provided another two guidelines or check detail guideline. So if you see this appendix 2, that gives different codes for different diagnosis, and you have to enter these the relevant codes based on the patient data into this form. So you say your patient, the diagnosis is upper respiratory tract infections, so you give the code as URTI. So like that, you have to cross check with this particular form and enter the data here. The next one is type of indication. So for that, again, if you see this appendix 3 here, it has different types of infection, and they have again given certain codes for that. So there is community acquired infection, hospital acquired infection has been divided into further categories. Surgical prophylaxis is there, medical prophylaxis is there. There are certain others, other categories of antibiotics, and unknown indication. So whichever relevant to that particular patient, you have to enter it in this particular option here, which says type of infection. So sorry, type of indication. So that is how you enter data into the global PPS form. And in addition to that, there is a freely available web-based web tool where you can convert all the paper-based data that you have collected into the website, which helps you to further analyze the report of the PPS that you have conducted. Okay, so now that you have understood how the different methodologies of conducting PPS, we'll move on to certain process measures. So process measures are basically some parameters which aim to capture information about the key processes that contribute to achieving the desired outcomes. So basically, these are some measures which you can assess in order to understand the antibiotic prescribing behavior, and also to see if your antimicrobial stewardship interventions which have implemented is working or not. So there are a set of different process measures which WHO has defined, and you can collect the data about these different process measures from the patient records and other details. So these are the various process measures as defined by WHO. So you can actually do the PPS to assess the various process measures. So now that you've understood the methodologies of conducting PPS, we will try and implement or try and apply those methodologies into these process measures to see how we can do a PPS and how we can analyze the data, analyze the patterns of prescription to the clinical teams. So some of the process measures include documented indication for antibiotic use, stop or review date, compliance with treatment guidelines, length of therapy, 48-hour review. So there are various process measures, and for each of these process measures, WHO has also given certain very easy, very easy to understand formulas. So we'll try and understand this better using a case scenario. In addition to these process measures, WHO has also elaborated on how you can use point prevalence survey to actually assess or evaluate any of these process measures. So they have put together a stepwise approach on how you can conduct PPS in a hospital setting to assess any of these process measures. So there's a 5-step process. The first one is structure and governance. Second is objectives and methodology. Third is preparation. Fourth is data collection and validation. And fifth is data analysis and reporting. So we'll understand these using an example. So from the different process measures that we saw in this slide, I've selected this one that says stop or review date. Just as an example, this is a hypothetical case scenario. So to just give you a better understanding of how you can do a PPS, I've just taken this as a hypothetical scenario. So here you see how to calculate this particular process measure is number of patients with a written stop or review date for an antibiotic treatment divided by total number of patients who are treated with antibiotics. Okay, so let's go back to our case scenario. So just think about this as a particular ward in your hospital. So it could be again, your medical ward. And say there are like 10 patients in this ward. And among these 10 patients, 6 patients are receiving antibiotics. And from here, you can see that about 3 patients among these have a stop or review date mentioned in the prescription. So this is the particular ward that you're looking at. So when you go into the ward, you don't know which patients are on antibiotics, which patients have a review date written in the prescription. You don't know anything. So you're just going into a ward which has like about 10 patients admitted in that ward. So now you're going to implement a PPS to look at how many of them have a written stop or review date. So the first step to implement a PPS is structure and governance, where you basically appoint a person or a team in charge of doing the PPS. So say in our case, the team in charge would be the antimicrobial stewardship team, and the designated person would be the AMS clinical pharmacist. So we have decided on that. So now you have a person who is responsible for conducting PPS in that particular ward. The second step is defining the objectives and methodology. So you need to define your objectives, select which PPS methodology you would be using for your survey, and then provide the necessary training for conducting that PPS. So in our case, we have decided that we are going to look into the stop or review date, whether it has been written for all antibiotic prescriptions in that particular ward. So that is our objective. PPS protocol, let's say we are going with global PPS methodology. And the third step is to train the clinical pharmacist who is responsible for conducting the PPS. So 2 steps are over. So first, we identified the team and the personnel who will be in charge of doing the PPS. Second, we defined the methodology, the objectives, and we have provided the necessary training for doing PPS. Now, the third step is preparation. So preparation includes getting the necessary ethical approvals and other permissions, deciding on when, like which date you want to do the PPS, and then getting all the materials for the survey ready before actually doing the survey. So again, coming back to our case scenario, say we have decided on which ward we are going to do the PPS. And before we do the PPS, like for any other studies, you have to get an institutional ethical approval. So before you initiate the PPS, you have to go to your ethics committee and get the necessary ethical approval from the committee. Once you have the ethical approval in place, you have to go and meet the relevant or the responsible doctors who are taking care of the patients in that particular ward, as well as the nursing in charges, and inform them of this point prevalence survey that you would be doing, on which date, at what time, and provide all the necessary details and get their permissions. And then you decide on which date you're going to do the survey. So we know that we are only looking at antimicrobial prescriptions which are active at 8 o'clock on a particular day. So say hypothetically we are setting our date of PPS as January 20, 2025, and we are going to look at prescriptions active at antimicrobial prescriptions which are active at 8 o'clock in the morning. And then you get all the necessary forms and other materials which are required for data collection ready. The fourth step is data collection and validation. So it is important that you first do a pilot survey to validate the data. Then you conduct your actual survey and then transfer the data from the paper-based forms to the electronic format. So in our case, the clinical pharmacist, they go and do the pilot survey, and actual survey happens on Jan 20. And the data from the global PPS forms is transferred into the electronic database. The fifth step is data analysis and reporting. So wherein you, once you have done your PPS, you clean and analyze the data, you report the results to the responsible clinical teams, you identify areas for improvement and agree on AMS interventions, and then you monitor and evaluate these AMS interventions. So when you are say reporting the findings to the clinical teams, there are certain things that you need to be mindful about. So this particular paper has actually given like a visual dictionary, you can say, on how you can present the findings of a PPS to the clinical teams. So they have shown which all visualization type can be used for what parameter. So whenever you are presenting such survey data, it is good if you can put together like a graph. So it could be like a line graph or a bar chart. Bar chart itself, you have different types. You have horizontal bar charts, you have vertical bar charts, you have group bar charts and stacked bar charts. So there are different types of bar charts. So depending on what variable you are presenting, you have to select a chart that is most appropriate for that parameter. Because if you mess up in that stage, the data that you present may not be easily conveyed to the audience or to the clinical teams. And if that data is not adequately conveyed to the clinical teams, then designing the interventions and actually bringing in an impact of this particular finding, you may lose that. So this particular step is very important. So depending on which parameter, which content you are choosing, please select the appropriate chart type or the visualization type according to that. And in addition to that, this paper has also given some do's and don'ts when you are preparing these charts. So when you prepare graphs, you might become very, very creative, and you might incorporate various effects and colors and things like that. But when you're doing such things, make sure that you are not messing up with the data and you're not making the data very hard to understand. So some things that these authors have asked to avoid is one, including like when you're choosing the colors for the bars, it is important that you pay attention to what kind of variable or what kind of parameter it is that you are reporting. So if it is categorical variables, so where you're just showing certain categories, then you can include different colors, so that will just pop up different categories. So say you are showing the different categories of antibiotics which are prescribed in that particular ward, so you can have one color for beta lactams, one color for tetracyclines, one color for aminoglycosides. So that gives you a clear quick understanding about which antibiotic or which class of antibiotic is mostly prescribed in that ward. But if you're giving like a ordered variable, that is, you are showing like a linear progression of high, mid, high to low, or low to high. In that case, it is important that you select a color palette that is representative of that. So say it goes from a light shade to a darker shade, and you're not using different colors there. So for example, if you are showing, say, antimicrobial consumption data over the months, when you are showing that, say, from Jan to December or Jan to June, that is like you are showing the same parameter which is happening over time. So it is always good to just show like select a color and just show it from light to dark or dark to light, and don't choose different colors there. So when you choose different colors, the participants or the audience might get confused as to what you're presenting there. So these are some very simple tricks which you can use to make your data reporting quite effective. And in addition to that, it is always good to avoid unnecessary adding shadows, adding 3D effects, putting background colors to your graphs. So just be very sensible about what is it that you're trying to convey. It is good to use, play with colors and mix things up, but make sure that you're not messing up with the data and you're not making it difficult for the audience to actually understand what is it that you're trying to present. And then they have also put together some do's when you're doing a graph. So it is good to select different colors over different shapes when you're presenting the data. Then when you're comparing sizes, it is good to prefer length. So having different length of bars rather than having different areas. So small area, large area, like that. And yeah, so I'm not going into too much detail here, but please refer to this paper. I have found this quite useful, and use these recommendations that the authors have put together when you're doing a graph and when you're trying to report the findings of a PPS. So these are some examples of how published literature has shown PPS findings. So this is from an ECDC paper, like a study that has used ECDC protocol. So there they have used pie charts. So I'm sure many of us have used pie charts even during our PharmD thesis. But many of the researchers now don't consider pie charts to be a very effective tool for visualization. So they prefer bar charts and other forms of graphs in comparison to pie charts. So some other ways, like I mentioned, you have bar charts. Bar charts are again horizontal, vertical. Here you see the stacked bar graphs. So stacked bar graphs help you to basically collate different variables into one graph. So here again, you can see they have put together different wards on the y-axis. And if you see here, the different colors actually show the different foci of infections or different healthcare associated infections. So from the length of each of these colors, you can basically compare how many surgical site infections are there in one ward in comparison to the other. So it's quite a very effective and very comprehensive kind of a chart. So here again, they have used the same stacked bar graph where where the authors have tried to compare access and watch antibiotics in different hospitals. So this is very easy to interpret also. So you can just look at the graph, and the green represents the access antibiotics. So you can see in one hospital, it is only 25%. In some other hospitals, it is 47%. So it's very easy for you to compare the results between different centers. You can also do it for different countries. So this is again another way of doing bar graphs, where the authors have actually compared the different antimicrobial consumption in the hospital. So one look at this itself, you'll understand that third generation cephalosporins are the mostly consumed antimicrobial in that particular setting. So like I mentioned, this is again a stacked bar graph comparing the data between different regions. So you have Eastern Europe, Northern Europe, Southern Europe, Western Africa, East and Southeast Asia. So different geographical locations have been marked on this graph. And for each region, they have shown in different colors what are the different antimicrobial classes that are consumed during that study period. So again, this is very quick to compare. So you can just see, you can particularly choose one class of antibiotic and see how it is consumed in different regions in the world. So these are some of the key ways in which you can report your findings of a PPS to the clinical teams. So coming back to our case scenario, so you have understood how you can do a PPS in your hospital setting, and what are the different methodologies and how you can present your findings. So just applying those principles and those steps into our case scenario. So we know that this ward has 10 patients. 6 patients are on antibiotics, and out of that, 3 patients have a documented stop or review date. So our percentage of patients who have a stop or review date documented is 50%. And so you present this data to the clinical teams. What next? So you put together a graph, a bar graph, or whichever one you feel is most appropriate for that scenario, and you show it to the clinical teams. And then you discuss with the clinical teams, what is it that we can do to improve this percentage. So 50% is not a great percentage, because we know that if a stop or review date is not documented for a particular antibiotic prescription, there are chances that it would be prolonged, the therapy would be prolonged unnecessarily for a longer period of time, which will again have implications on the patient's health as well as financial constraints to the patients. So it is very important that there is a particular deadline or a particular date at which the antibiotic would be either stopped, or at least on that particular day, the clinical team would re-evaluate if the antibiotic should be continued or should be discontinued. So you discuss this issue with the clinical teams, and you try and co-design interventions with those clinical teams. So rather than you as a stewardship team member just going and telling them, okay, from tomorrow, this is what you have to do, rather than that, sit with them and see how is it that you can improve the compliance to this particular process measure in that particular department. So probably what you could do is you can just modify your if you have a dedicated antibiotic prescription chart in the patient file, you can maybe just modify that chart to include a particular column that says stop or review date. So when it is there in the prescription, the prescribers also remember to write that day, and it is easier for you also to evaluate. So if at all in your hospital the antibiotics don't have a separate chart, maybe that is a starting point for you. You can create a specific or a separate antibiotic prescription chart in your patient file, and in that particular prescription chart, you can have a slot for documenting the indication for antibiotic, as well as writing a stop or review date. So that actually prompts the prescribers to put it in paper, rather than you keep going back to them and saying you have to write it. If you don't write it, it becomes an issue. Rather than that, put it on paper, and that actually prompts them to do it. So you have, so this is just an example of the intervention that I'm suggesting. Whatever works for you, that particular department, you have to discuss it with the clinical teams and decide. So once the clinical team is on board with you on that particular intervention, you implement the intervention, and then you do continuous review to see if the intervention is working or not. So now, without any intervention, your compliance to stop or review date documentation is 50%. Say you have implemented an intervention introducing a particular specific column in the antibiotic prescription chart to write the stop or review date. And then in the next few months or few weeks, you continue the audit to see if that intervention is working. So for example, we started off at 50 percentage, and then you continue, you implement the intervention, and in the subsequent months you continue to audit if the intervention is working or not, and maybe you will see that the percentage of compliance is improving gradually. Sometimes you'll see that it is declining, and in that case, again, you have to go back to the clinical teams, and you have to meet with them, and you have to ask them, like, why is it that it is not working? What could we do to improve that compliance? So always have that rapport with the clinical teams for your interventions to work and for improving patient care. So in addition to this routine input and feedback to the clinical teams, it is also beneficial if you have the capacity to publish your results as well. So I think in all my presentations, I always try and highlight the importance of publishing. So this is one global PPS publication that has come out from India, where 16 tertiary care hospitals have collaborated on this study, and altogether they have evaluated 1,750 patients, of which 1,005 were receiving antimicrobials. And this PPS found that that is documentation of reason in notes and post-prescription review score was very low. So whenever you're doing these kind of surveys, it gives an idea about the consumption patterns, prescribing behaviors in our country as well. So if you have the capacity to publish, I would really encourage you to publish. If you're not publishing, it is at the minimum, it is important that you provide a feedback and provide the report to the clinical teams, and try to implement interventions to see how you can improve that compliance rate. So I think with that, I'll conclude my presentation. Thank you so much for your patient listening.
Yeah. Uh, Firstly, thank you so much for simple, clear, and complete, like giving complete information, ma'am. It's really very engaging.
Thank
Almost
you.
within 30 to 40 minutes, you covered each and every step that is required to understand PPS and to perform the PPS. I hope
Thank
definitely
you.
I learned many things from this session. I hope the same with our audience. And there are a few queries.
Yes.
Shall I go ahead, ma'am?
Sure, sure.
Yeah. You have mentioned two important PPS, like one is WHO, one
Hmm.
is global.
Hmm.
So, out of this, as per the understanding, this WHO has many forms, and this was made very simple in global, having only two to three maximum forms. So, as per the performing, I mean, for us talking would be very easy, but when you are performing on ground, so what do you feel, ma'am, like which one is like very user friendly, followed by which we can get robust information? So what do you comment on this?
So I don't have any experience using the WHO PPS methodology. I have used the global PPS methodology, and I can say from my experience that global PPS is quite user friendly, because the two appendices that I showed you on the indication and diagnosis, that is already
Yeah.
there along with the form. So it's very easy for you to refer to that and fill out the forms. And like you mentioned, the number of forms are also less. And when we did it also, we found it very easy to do. So the publication that I showed you at the end, we had actually I had also contributed to doing the PPS part of it. And
Okay.
so we use global PPS methodology there. So I'm not in a position to actually comment on the how easy or difficult it is to do the WHO PPS. I only have knowledge from what I've read. But global PPS, definitely, I found it very user friendly. And you also have a free web based tool for global PPS where you can easily enter the data that you have collected onto their website. So if you are
Oh,
if you're collaborating with different hospitals in India, or in say in Kerala, you are doing this PPS among various hospitals in Kerala. Each hospital can enter their data onto this global PPS platform, this website, and it becomes easy for us to just compare the data with between different
mhm.
hospitals and put together a report.
Yeah, great, great. So, like we have, as per the like guidelines saying, we have only implementing this PPS to understand the hospital admitted patients. So these days, OPD settings are also most important to understand the antimicrobial prescribing patterns, because this is an area where we are like need to focus
Yes.
on. So what
Yes.
do you say, ma'am? Like, will this be even helpful for tracking the OPD prescribing patterns?
OPD prescribing, again, it become PPS. I don't think it may be a very useful tool when it comes to OP settings, because
Okay.
PPS, it happens only at a point of time. So you can't say
Yeah.
that for OP patients. So if you're saying 8 a.m. antibiotics which are active at 8 a.m., you can't evaluate that part,
Mm.
because patients take the
Exactly.
antibiotics, they go home. So how
Yeah.
many of them are actually taking it regularly? I mean, for the prescribed duration, how many of them have active prescription at that point of time? That becomes very difficult to assess. I don't think PPS is the right methodology for that. But we could
Mhm.
definitely think about doing OP stewardship models where you can have like audit and feedback. So clinical pharmacists can actually evaluate OP prescriptions and see antibiotics which are prescribed in OP, whether it's complying to the guidelines, whether
Mhm.
it is the dose, duration, those things are appropriate, and then provide a feedback to the prescriber. And like
Yeah.
even if it's like a post prescriptive review, and
Mhm.
say the patient came and got the antibiotics in the morning, and you're doing the review only in the afternoon, maybe you can still, if you find a very gross error and a very major error, you can still have a potential to just give a call back to the patient and correct the
Mhm.
prescription. So probably audit and feedback is more a better method of assessing antibiotic prescriptions in the OP setting.
Okay. Yeah. Very sensible. And also, ma'am, when we are dealing with stewardship, the main picture comes into the policy is like antibiogram. The backbone of everything is like antibiogram. So when we are like dealing with this PPS, is it possible for us to understand this MDRO patterns? Is there any scale to measure this, ma'am, in this PPS study
Yeah,
surveillance?
so in the PPS forms, they have a column to actually collect data on the microbiology reports. So there, when
Okay.
you enter the sensitivity patterns, the culture results, using that data, you can probably get an idea about the different rates of organisms, resistant organism patterns. But again, it may not give you the complete picture. Like I mentioned right at the
Yeah.
beginning of my presentation, PPS only gives you what is happening in a snapshot of a time. So at 8 a.m.,
Yeah.
at whatever the time is, only at that particular time, what is happening, you get an idea. So
Yes.
you may not, I wouldn't suggest using the PPS data to actually create an antibiogram, because you might be
Okay.
missing out on a lot of data. So if an antibiotic was prescribed before 8 a.m., like it was discontinued
Mhm.
before 8 a.m., you won't be able to capture it in your PPS. Or if the
Exactly.
antibiotic was initiated, or if the culture report came after 8 a.m. on the day of the survey, you won't be able to capture it. So it doesn't give you an
Okay.
overall picture. It only gives you an idea, like uh, uh, yeah, a snapshot of what is happening in that particular ward, what is the resistant patterns, those things. But
Okay.
definitely, I'm not
Okay.
saying PPS is a bad methodology. It is a very useful methodology, especially if you are like starting up with your stewardship activities in a hospital. You want to understand
Mhm.
what is your prescribing behaviors, what is your prescribing patterns. PPS is definitely a very good starting point. And also, once you
Mhm.
have implemented certain interventions to see if your intervention is working, you can definitely do a recurrent PPS, routine PPS after the intervention to see how your intervention is impacting patient care. So, for those aspects, PPS is definitely an amazing tool.
Oh, great, great. Understood. And one more query is like you mentioned the way of presenting this aware antimicrobials, aware list of list of antimicrobials, but that was suggested by WHO. So based upon the like country or the based upon the usage in the hospital, the list of watch and reserve would be changing. If something misuse happens, they'll convert that, they will consider it as an something need to give a focus. So at this kind of scenarios, when a misuse is going, so can we consider aware as an list of thing, or should we modify it when we are measuring this PPS, when we are using this PPS, ma'am?
So that graph that I showed was actually a published paper. So there
Yeah,
you're not actually trying to do any kind of comparison or to evaluate the prescription there. That graph is only showing in the prescriptions that they reviewed what percentage of antibiotics came under the access category, what percentage came under the watch category. That's it.
exactly.
So it's not showing whether it is appropriate, it has to be modified. Nothing like that is being conveyed in that graph. So
Mm-hmm.
like how you put a graph of say how many what proportion of the antibiotics were in the beta lactam class, or how many were in the amyloglycoside class. So in the same way, they're just trying to give the categories of antibiotics in that particular ward during the day of the survey. That's it. So it's
Okay,
difficult to
okay,
further interpret that and put out further findings from that particular graph. It's just a data visualization just to understand, okay, in hospital A they are prescribing more watch category, in hospital B they are prescribing more access category. So we also know that when when watch category antibiotics are more, then it's a problem. When reserve category antibiotics are more, it's a problem. So in those aspects, that graph is useful, but you can't actually deduce any further interpretations with regards to appropriateness, inappropriateness from that.
oh great, great. That's to know. And also to measure these IPC practices are followed by outbreaks. So PPS, there are like few literature supporting like PPS can work. What do you comment on this, ma'am?
I think it will definitely work because in global PPS, you have a section specifically dedicated for HIA infections. So you are looking into the different lines and tubings, and even in the diagnosis indication, when you're entering those data, you are segregating the prescriptions into hospital acquired, community acquired, and in hospital acquired itself, which is the foci of infection. So
Mm-hmm.
to an extent, you would be able to get an idea about HIA infection rates, but I don't think it will substitute for your routine IPC surveillance. So that's definitely the
Yeah,
ideal way of doing it. But again, I'm saying PPS is not an alternative for doing audit and feedback or routine IPC
exactly.
surveillances. But it is definitely a starting point, and it definitely helps you to get an immediate result of how your intervention is working. So,
True.
so for example, if you are implementing audit and feedback, you can like at regular intervals, if you are doing a PPS, you'll understand if your feedback mechanism is working, if there is any change in prescribing pattern. So, in that aspect, definitely PPS works.
Exactly. Exactly. Thank you so much for answering all the queries, ma'am. Really, it is a very helpful and followed by very important session that every intern followed by CP need to know when they are establishing this AMSP or implementing AMSP in the hospital settings. Thank you so much again for taking your time and giving a wonderful talk on the important aspect. I hope
Thank you
this would
so
be
much,
very
Satya.
helpful for the audience.
Thank you so much.
Yeah. Thank you all once again. I want to mention that if you have any queries, kindly please drop down the queries to FCPI official mail. So your queries would be answered there. Thank you once again.
Thank you.
Bye bye.
Bye.